As physicians, we're trained to take care of patients, but unfortunately, we have now recently been reduced to secretaries, transcriptionists, and now coder and biller. We unfortunately have to understand the nuances of coding and billing, and I'm here today to answer someone's question. Hello, my name is John Lin. I'm a private practice urologist here in Gilbert, Arizona. I'm also the founder or administrator of the Thriving Urology Practice Facebook group. And I'm here on a beautiful Sunday afternoon to answer one of our members' questions on coding and billing for prostate needle biopsies in men suspected of prostate cancer. So her question came through the listserv, and Andrea asked, I have a question regarding prostate biopsies. Our coders frequently change our billing. So despite what she codes and builds, apparently her coders change her billing and codes. And she says, I know there are different rules for Medicare versus private. So that's a very good understanding there. My question is, what do you bill for prostate biopsy? In the past, we could bill for the block, ultrasound, and guided biopsy, but now they said only bill 76872, which is the ultrasound, and no longer 76942, which is the ultrasound guidance, or 64450, which is the peripheral nerve block. So much to unpack there. First of all, in the past, you should not have been billing for the nerve block if we're talking about Medicare. And we need to start with the payer first. Number one, the payer needs to be determined. If it's Medicare, and I'm going to concentrate on talking about Medicare today. If it is strictly Medicare, then there are specific codes which you should have billed for in the past, and nerve block ain't one of them. Okay? So the payer is the number one determination regarding what codes you use for billing and coding. That is then followed by, where are you actually doing the procedure? Is it in the surgery center? Is it in your office? Or are you doing it in the hospital and you don't own the equipment? So place of service code obviously makes a big difference, and I'm sure your coders and billers are using the correct code, I hope, so that you are actually getting paid for the services that you provide. If you don't own the equipment and you're going down to the hospital, your doctor is going down to the hospital to perform the procedure, then obviously a modifier 26 is necessary, because you would only bill for the professional component of the codes that you perform, the procedures that you perform. All right. As of November of 2016, CMS and the National Correct Coding Initiative came out with a new guideline. And what they have done is they bundled a couple of codes. All right. So now, in the past, here is the list of codes that you could have used. Now this is including both Medicare and private payers. So let's look at these codes. 76872 for the diagnostic ultrasound, 76942 for the ultrasound needle guidance, 55700 for the actual biopsy, and also what you talked about, 64450 for the peripheral nerve block. And if it's a private payer, some payers are actually reimbursing A4512, which is the prostate needle. All right. In November of 2016, NCCI changed the rules. And unfortunately, that's just the nature of the game. The rules constantly change, and unfortunately, we have to keep up with the rules so that you are actually adequately paid for the services that you provide. It's an unfortunate fact of life for physicians, but in any case, they bundled 76872, the diagnostic ultrasound, with 76942, which is the ultrasound guidance. Then if you perform the biopsy, you would obviously bill for the 55700. Now, this is we're talking about Medicare patients. So Medicare patients, you would do this. But private payers, the rules vary. So you're going to have to ask your private payers, or sometimes it's kind of a game. You have to build for the codes and then see what comes through, what is paid and what is not paid. It is truly a game, unfortunately. But let's stay on topic here with Medicare. For Medicare, it's either 76872, which is the diagnostic ultrasound, or 76942, the ultrasound guidance, plus the 55700 if you are performing a transrectal ultrasound of the prostate in your office, and we're talking just Medicare. All right, so you pick one of the two codes on top, either the diagnostic ultrasound or the ultrasound needle guidance, and you bill for the prostate needle biopsy. Basically two codes in 2018. That's what you can bill for when it comes to a Medicare patient, and when it comes to prostate needle biopsies, transrectal ultrasound, and prostate needle biopsy that you perform in the office. Now, the American Urologic Association says that if you routinely do transrectal ultrasound needle guidance and diagnostic ultrasound of the prostate, one of the things that you can do is to have the patient come in on one day, perform one procedure, and have the patient come in on another day, and then they bill for the other procedure and do the biopsy at the same time if it is clinically warranted. But in my practice, I do not do that, because it's an extra trip for the patient, even though coding wise you're going to be shortchanged because you're going to be doing the procedures and not getting paid for it. For the convenience of the patient, I will perform the diagnostic ultrasound, the ultrasound needle guidance, and the transrectal ultrasound biopsy on the same day, and simply bill for two on the Medicare patient and lose out on the other. As far as which codes you would use, that is really up to you. Now, you can bill for 76942 ultrasound needle guidance and 55700 prostate needle biopsy. Or here's the other scenario, 76872 diagnostic transrectal ultrasound of the prostate and 55700 for the prostate needle biopsy. So either one or the other would be applicable for you depending on what you actually perform. So of course you would bill for what you actually perform, and if you did both, you would probably pick the one with the higher RVU, so you are less shortchanged than if you were able to bill for all three different procedures. Anyway, those are the rules we have to play by. These just came out not too long ago, at the end of November 2016, beginning of 2017. Not all the practices are aware of this, and based on what I've been hearing, so your confusion and your coders and billers confusion is not surprising to many of us. All right, if this is confusing, I get it, because it is still confusing to me, and I have to go and learn new rules every single year. And one of the places I used to go is through PRS Network or the Urology Advanced Coding and Reimbursement Seminar. And I will go ahead and put the link to the 2018-2019 seminar in the video description. If you want to attend, it's at the end of November, early December in Las Vegas. It is worthwhile. After attending the course for so many years and been very fortunate here to be able to run a great practice, I have been invited to speak again so I could teach the course, certain portions of the course, to fellow urologists, coders, and billers. If you have questions like this, or how to run your practice better, whether or not to implement a new technology in your practice, I think the Urology Advanced Coding and Reimbursement Seminar will be a great place for you to check out, interact with fellow billers, coders, office managers, urologists, and who knows, you may pick up something new and bring something valuable back to your practice so that you could be successful in whatever you do. Lastly, I know this is a pain in the butt. It is coding, it is billing. Let's not forget one of our main tasks as urologists, which is, for me, to make America pee again. All right, guys, have a great rest of the Sunday. Take care. If you have any questions, please leave them in the comments below. I look forward to interacting with everyone. Take care.